ethics of the profession and which instills confidence in their abilities. You're not only going to be trying to conform to the ethics and the rules and regulations of the department, but also the rules and regulations that we lay down for you here. You also, remember, you're dealing with patients. So you want to make sure that the patients aren't concerned about your professionalism. The fact that they introduce, either the therapist or yourself will introduce yourself as a student, that sort of lays the groundwork for the patient. Oh, she's just a student, or he's just a student. But you still have to look and act professional. Which means if you have a problem or you don't know what to do, you do not talk about it over the patient. Does that make sense? You don't look at the therapist on the other side of the patient and say, I'll understand what I'm supposed to do. Or, words to that effect. That doesn't bode well for the patient. Any student who does not adhere to the scholastic and professional standards of the school and its clinical affiliates is subject to dismissal. I've never had to dismiss a student for that, and I hope I never will. But it's there. The situation is based on unacceptable, intolerable, illegal, or unprofessional actions which violate clinical policies set forth in the handbook, which you'll get, or which violate any local, state, or federal laws. The student will not be allowed to re-enter the program at any time in the future. So if you get thrown out for this, you're not going to come into the program again. Questions? It's pretty straightforward, isn't it? Okay. Sorry. Okay. I have to do it this way. I'm going to have to take one of these. Okay. So infection control. Students are advised as part of the routine of working with patients in the medical setting, exposure to contagious and pathogenic organisms may occur. Have to abide by the safety rules and regs that govern the clinical facility. Infection control precautions generally include covering of all cuts, wearing of gloves when exposure to body fluids is likely, and washing hands after each patient or when leaving the clinical setting, or when going for lunch, or going for a break, or, do I need to say this, after using the toilet? Some people just have to be spoon fed on that one. Does this make sense? Okay, good. This is what we call what? Pardon? Hygiene. Okay, yeah. Universal precautions is what I was looking for. Okay.
I just thought of washing hands.
Okay. So, universal precautions continued. It's not always possible to identify when exposure to communicable disease takes place. Students are urged to apply universal precautions at all times. In the event that a student is exposed to blood or body fluids or to any communicable disease, a student must immediately inform the clinical supervisor or the chief therapist and me. So what, apart from the blood and body fluids, what other communicable disease could you be exposed to in a clinical setting? Anybody?
Respiratory issues? Or like respiratory, like TB or?
TB, yeah, you could. Not very common these days, but it's possible. What else? MRSA. Okay. Normally you're advised that a patient has MRSA so you can take precautions. This means if you don't know. So things like chickenpox, measles, TB, HIV. But then that would be blood and body fluids. What's the adult version of chickenpox called? Shingles. Shingles is probably the one thing that you may mostly be exposed to. And MRSA and C. diff. But you should know in advance about those three. The therapist should be advised, and you be advised, so that you can take precautions against shingles, MRSA, or C. diff. Following information should be gathered if you have a exposure. The therapist will talk you through it, but the patient's name, the ID number, the time and date of exposure, and the type of exposure. Incident should be reported and filed to the incident, and student should report to the employee health officer or the ER for prophylaxis. Okay, dress code. Scrubs, white shoes, 3/4 length lab coat, or, you know what I mean by 3/4 length lab coat, that.
The longer one.
Something like that, okay? Clothing to be clean and pressed at all times. That's one I added last year because one of the students I got a phone call saying, student looks as if she slept in her scrubs. And I thought, okay, yeah, that is not professional. ID badge. You should all have your ID badges by then. Do you all have your ID badges? Do you all have them on? Wear them. Because security can call you up at any time and say, where's your ID badge? Where do you belong? And if you don't have it, I'll get a phone call. Because if you tell them where you are, what the program you're in, I'll get phone calls. And I don't like getting phone calls from security. Hair should be clean and long, and if it's longer than shoulder length, it has to be fastened back, just like you have at the moment. For the guys, maybe. Mustaches and beards must be neatly trimmed, no scruff. No scruff. If it looks as if you haven't shaved for 2 days, shave. There are some departments who will send you home. Cosmetics and jewelry should be kept to a minimum and should reflect a professional appearance. So what does that mean? To you, what does that mean?
You mean kept to a minimum? What does that mean?
Yeah.
Just like wedding rings.
It shouldn't impede your interactions with your job at all.
Like what, for example?
Like 100 rings on your hands
Mhm.
and a big thing that hangs down and hits your patient in the face when you lean over them. That kind of
Like
stuff.
this.
Yes.
You should never, long earrings, dangly earrings. You should never wear your lanyard. You should never do this if you're in a clinical setting. Always just have your name tag on a clip. Everybody knows what that is, right? Yeah. So never have something hanging around. I saw someone almost strangled by the name tag because it was unintentional. Patient was trying to help himself up, and instead of grabbing the shoulder, they grabbed this. It wasn't funny. The girl had marks around her neck for days afterwards. So.
Who thinks to do that?
Huh?
Who would think to do
that? Let me just grab your neck here.
Well, what happened was he was trying to grab her shoulder and his hand slipped and he was falling backwards
Oh,
and he just grabbed something. And it happened to be her lanyard. So, yeah, be careful. Same thing with dangly earrings. I've seen earrings getting pulled out by patients, so you don't want to do that. No visible tattoos. All tattoos have to be covered. I had one student in California who had a tattoo right here. And when she pulled her hair back, it was fine. But if it was loose, you could see it, and that was a no-no. So, yeah, no visible tattoos. If you have tattoos on your lower arms, cover them.
Yeah, I can't get a face pat. I'm not being serious. She looked at me like, are you crazy? She's just throwing down the-
Actually, that's not surprising. That's really not. I had a male student in California who had a tattoo right here.
So what did you have to do?
He wore a turtleneck. He wore
my God.
one of these,
Put makeup on.
one of these sleeves, but it had a high neck.
I'd rather just put a
Band-aid,
So he had to-
yeah, Band-Aid or
Yeah.
something.
Yeah,
Forget
but
that.
no, it was big.
Oh, God.
No, so he had to wear a collar, like a.
He probably thought he was weird.
In the northern climes, you can get neck pieces for underneath sweaters. Have you ever seen them?
Yeah,
Yeah.
I forget what they're called.
A dickie, yeah, something like that, but it has to be up high. So anyway, that's, yeah, okay. Perfumes and aftershaves must be avoided. Why?
'Cause they're sensitive to
Allergies.
smell.
Allergies is one thing, but that's
Well,
not the
I
main
kind of
thing.
meant like the sensitivity.
If you have a patient who is they're going chemo and radiation or just radiation, they are very sensitive to smell. So if you have somebody leaning over you, think about it, if you have someone leaning over you and you're exuding perfume or aftershave, that's not gonna make you any better. It's gonna make the patient sick. And you really don't want to have vomit all over the place, so. In all seriousness, no, you don't want that. Nails must be closely trimmed and only clear nail polish. Artificial nails are not permitted. No kind of artificial nails. Why not?
That's serious to get on the
Yeah, I mean, they can get underneath your normal nails too, but normal washing will get that out, but the artificial nails, no. One earring per ear is acceptable. No other visible piercings, so who had the double ears? You, okay. They're small enough that you're probably okay. But, what we're worried about is things going through the nose or through the ears that are big and bulky and stuff. And it says, any variance with these standards will result in students being sent home to get their nails taken off. Sounds evil, doesn't it? So clinical evals. Student will receive an evaluation at the completion of its rotation. These evaluations provide useful feedback as to the student's clinical progress. All the therapists that work with you can put input into this evaluation. It is, however, the student's responsibility to request that the evaluation be done and to give the appropriate forms to the staff. Now, I will be giving you an electronic copy of the student manual in the next couple of weeks. You need to look through it and we'll go over it and make sure that you know what you're doing. Because there's nothing worse than going into a site and they'll say, okay, what do you need to do? I don't know. Yeah, you don't want to do that. Attendance. Students' grade for the clinical portion is based in part on attendance. Obviously, if you're sick, no one is going to expect you to be there. Student will be assigned a clinical rotation. Copy of the schedule will be given to the student at the beginning of the semester. You're expected to attend as scheduled each day, and you will have timesheets to fill in, and these come back to me. If you're assigned to a clinical facility and it will be, next semester will be 3 days a week for 8 hours a day, I expect you to be there 8 hours a day. If the patients are not there, if say you're there from 8 till 4 and the patients end at 3, you can study for the next half hour or an hour. There's nothing to say that you have to go unless they're shutting down the building. So make your time worthwhile. Obviously, falsification of the timesheets. I put this in because some people don't have common sense. Let's face it, some people don't have common sense. So falsification of these timesheets will be considered a major breach of conduct, and it may result in termination of the program. So, completed timesheets must be turned into the program manager at the end of, I put each clinical rotation, but I'm going to change that to the end of each 2 weeks. Timesheets will be compared to those from the clinical agency where you were attending. So they may keep timesheets of their own. If they do, then they'll be compared. Okay, tardiness and or absences. If you're stuck on 95 or 295 and there's an accident or some such thing, then you have to call. Normally, your schedule should start at 8 unless the clinic wants you at a different schedule. So if you're not going to be in, you're sick, you're in bed, whatever it happens to be, call both myself and the site. If I'm not at my desk, leave a message. You have my office phone number, you have my cell phone number. Please use them. The system automatically puts a timestamp on each message. So if the idea is 15 minutes before you're due to start. So if for some reason they're starting at 7:30 and you find yourself stuck in traffic and you know that you're not going to be there for 7:30, call the site, call me, leave a message. And if this doesn't happen, usually I give 1 free pass. Next time it happens, verbal reprimand. Next time it happens, a written one. I don't want to see it happen again. So you don't want to miss anything. Although this is a competency-based program and there's no actual number of hours you have to do, you need to take advantage of every hour you can get, because even if you've completed all your competencies, you need to gain experience. So, Please do not miss any clinical if at all possible. Oh, this shouldn't be it. This I took out, so, whoops, sorry. It won't go back. Okay. Okay. So, competency requirements. Radiation therapeutic procedures listed demonstrating appropriate radiation safety, equipment operation and quality assurance, treatment verification and prescription verification, consideration of those critical structures, patient and machine setup, record keeping, patient assessment, care, management, and education. Okay, it is a competency-based program. So you have to demonstrate competency. You'll be given certain competencies to you to do. We will go through them later. The student may perform the competency only after they've observed and assisted with a minimum of 3 procedures as noted in the clinical log. Minimum passing grade for all competencies is 90%. And you'll be allowed to repeat it twice. So the idea is if you want to do, say, a chest competency, the patient lies on the bed, get it set up, whatever. You should have seen that patient at least 3 times. The therapist should say to you, okay, I think you're ready to comp this, to finish the competency. Then you go in and you do it with some help from the therapist. It's not sort of you go in on your own and do it. There's always one therapist in with you. Because to treat a patient, there's always 2 people, right? Minimum. So you and a therapist will be in there. You will be in charge. You will tell the therapist what they need to do. So think about that. You're not going to do too many competencies right off the bat. You may do 3 or 4 next semester. The majority of the competencies will be when you get a little more comfortable. So that would be the following 2 semesters. So if the student doesn't successfully complete the competency, you go back to observation and assisting until proficiency is achieved. If a student fails the 90% proficiency on the first attempt, a competency must be repeated not on the same day and graded until an average of 90% is achieved, unless the patient is BID. You can do that if it's a patient is BID. And only 2 repeats will be allowed. You have to complete competencies in all categories to be eligible for completion of the program. And the competencies requirements is outlined by the ARRT. And the competency requirements are included in the book that you will get. There's a procedure list. So for treatment, you will need to do a competency in, let's start from the top, brain, primary and metastasis, head and neck, primary and, curative and palliative, which means IMRT or non-IMRT. Chest, IMRT or non-IMRT, and non-IMRT. Abdomen, same. Pelvis, same. Extremity, same. Spine, same. You have CT competencies. You have to do all of the above. So brain, head, neck, chest, abdomen, pelvis, extremity, and spine. You're going to have a very busy few competencies. Okay. Once a student has completed a particular competency, he or she may be asked to demonstrate the procedure at a time as a spot check, any time at a spot check to ensure retention of knowledge and skill. So just because you have done a chest competency, it doesn't mean that you can forget what you've learned. The therapist can come along and say, okay, you do Mrs. Smith. I'll stand and we'll do it together, but you're in charge. Because we just did a competency a couple of months ago. So you show me what you've done. Anytime a student performs a procedure on a patient pre or post competency, she must have a registered radiation therapist present. You are never, ever left alone with a patient. You always have someone watching you. The student will be 100% supervised at all times while in the clinical area. If you're in CT, then the CT therapist or the CT tech. If you're in dosimetry, then the dosimetrist is keeping an eye on you. If you're in the nursing area, then you will have to do a nursing check. If you're in a nursing area, then the RN will be keeping an eye on you. Okay, so these are the minimum core clinical competencies. You don't stop when you reach the minimum. You get more experience as you go through. Students demonstrate competency in 20 of the treatment procedures. Demonstration of competencies does not require delivery of treatment. The student must demonstrate competency in all 7 treatment simulations, or either a conventional or CT sim, or the treatment machine may be used. 14 competencies for dosimetry, beam modification devices, and general patient care. And competency demonstration should incorporate patient-specific variations, such as age and pathology. So you could do a competency on a palliative brain who is 85 years old, or you could do a curative brain on a 25-year-old, or both. Checklists should be used to record competencies. The checklist should not be sent to the ARRT. This is for your own benefit. The checklist for the student's use only, to keep track. Anytime that you do a competency, and we'll go through these later, anytime that you have a competency, it must be signed or initialed and signed by the therapist who is doing the competency with you. So you have to sign it, the therapist has to sign it, and the therapist should go over the comments with you. So it could be as much as or as little as, good job, thanks for doing it, or it could be a letter or a missive, yeah. So it depends entirely on what the therapist wants to see. While it's recognized that employment may be financial necessity for some students, working full-time when enrolled in the therapy department is difficult and not recommended. Students in the program will not be excused from clinic or classroom activities in order to pursue employment. Additionally, should a student be employed by a clinical affiliate of the program, they may not use employer time to substitute for program clinical time. At no time in the program will a student be scheduled for more than 40 hours a week in class or clinic. So, to make that clear, if, for example, you are in one of our clinical facilities, say UF downtown, and you're a patient care tech in the ER, and they're going to give you some overtime, makes more money, right? The overtime. But you're in clinical at the Proton Center. You cannot leave the Proton Center to go and do your work. That is not allowed. Does that make sense? Okay. So these are the form numbers. So these are some of the clinical competencies. So it's not showing up on the screen. Okay. So brachytherapy objectives. Clinical attendance. This is your timesheet. Clinical objectives. Dosimetry objectives. Orientation objectives. Preceptor eval. Patient care and nursing. Simulator competencies. Student skills tracking. Treatment competency and treatment unit objectives. So the treatment unit objectives would be things like you go into the room, where are the emergency stop buttons? How do you move the bed? How do you move the gantry? Etc. The orientation objectives, you walk into a new clinic and someone will take you around and show you where the chief therapist's office, where the doctor's offices are, where the review rooms are for patients, where the waiting rooms are for the patients, where the treatment machines are, where the break room is, if we have a break room, etc. Where the fire extinguishers are, where the fire exits are, etc., etc., etc. Okay. So, there are a number of common aspects to each form that are present the student must fill out. Generally, the rest of the form is filled out by the clinical preceptor or the program director, which is me. Instructions for the clinical preceptor's portion is contained in section 6 of the manual. General information for most forms is your name, the date, facility, the clinical site name, the preceptor's name are all on that form, at the top of the form. So, facility and clinical site name. So, we have UF, University of Florida. We have 2 sites. One is in Gainesville and one is downtown. So if you put, the facility would be University of Florida or UF Health, call it what you will. And then it might be Proton Center or Gainesville, whichever it happens to be. We have 2 sites for Baptist. One is downtown, one is the south, Baptist South. So obtaining signatures from your preceptor are very important. Preceptors is very important. Generally, if the preceptor does not sign the form, then the competency is not valid. Students' responsibility to politely ask or request that the clinical preceptor fills out the form, provide any feedback, and obtain a signature. The clinical preceptors obviously are busy, but appreciate that the student is trying to learn. If you have any problems obtaining signatures, please let me know. Once the forms have been signed by the clinical preceptor, it's the student's responsibility to submit the completed form to my office on the first classroom day after your clinical experience is over for that week. So if you're going to clinical, say, Tuesday through Friday, and you're coming in for class on Monday, then you bring in the forms with you. Generally, late forms are not accepted, and the student will have to repeat any clinical forms, any competencies that were on the forms that did not make it to the office. The one thing I haven't written here, and I should have, is that make copies of them before you give them to me. So if you do a preceptor, if you do a competency, the preceptor signs it, you sign it, it gets dated, and the preceptor says, good job, here you are. You copy it, you send me the original, or you give me the original. At the end of each clinical course, you'll be asked to fill out a clinical preceptor evaluation and submit it to me. So at the end of each clinical rotation, you will be asked to do an evaluation on your preceptors. So if you only had 3 people working with you, 3 different therapists working with you throughout the term, then you could do individual ones for each of the preceptors, or you can do a combined one for all 3. If they were all very good and everything was good and you had, balloons and whatever's, you can do a preceptor evaluation for all 3. If, however, one was better than others, or one was not as good as the others, you can do individual ones. This particular form is anonymous. You do not give it to the preceptor. You will send it to me. You do not have to sign it. So it really doesn't. What I do is I combine them and give a compilation of what was said to the site so that we know. And this is to go hand in hand with the preceptor evaluation of you guys at the end of each competency. So this is not a very good sign, but this is the student competency procedure and tracking. So you'll see this one is CPR certified. It's vital signs. I'm going to sign all these for you. So quality control procedures, the LINAC, output and symmetry, you'll need to see that with the physicists, the lasers, and then this is, okay.
The cardinal
Yeah.
rule. It really just goes straight to black. Why?
It was the end of the.
You would think that you would want to be able to touch it if it's that smart.
Yeah, so the simulation procedures, you have brain, head and neck, thorax, breast, abdomen, pelvic, skeletal. And then you have the symmetry. And then on the next page, which I don't have, is the treatment competencies. This is just a quick run through, but we'll go into more detail later. Any questions on what we've said, or I've said? Yes, ma'am.
Okay, so what happens if you fail 2 competencies and you only have 2 chances? What happens then?
You actually have 3 competencies. You have 3 chances. You have the first one and then 2 reviews. Normally, I would meet with the preceptors and find out what was happening, and meet with you as well. And see if we can, maybe it's something that you're not getting, or some kind of concept that you're not getting, or perhaps they don't explain it well, or whatever it happens to be. But to be honest, I've never had somebody do that. So
That's good to know.
the thing about it is that the therapists will not let you do a competency unless they think you can pass it. And the other thing is that for some people, actually most people, if you say, okay, you're going to do the competency on Mrs. Smith tomorrow, you're going to panic and you're going to worry all evening about doing this competency with Mrs. Smith. You know what you're going to do, but you're still, So what a lot of therapists do, and I did it when I was clinical, is I would just treat it as another day and come in with the student, and we'd do the patient, and I'd say at the end, okay, you've comped that one. So it relieves the tension. And I think it's a better way to do it, but it really does depend on the individual person. So if you think that you're ready to do a competency on somebody, tell them. Ask their advice. Do you think I'm ready? I think I'm ready. Do you think I'm ready? So they'll either say, okay, or let's see you practice it a little, maybe 1 more or 2 more days. Most of these patients are on for 5 and 6 weeks, so you usually have time to do it. Does that make sense? Okay. Yes.
How long, because I noticed on some of the slides it said at the end of clinical rotation, how long does a typical clinical rotation last?
Well, normally they would last the number of weeks that the semester lasts, which is 15 weeks. But depending on the number of clinical sites that we have, we may swap you around in the middle. So you may have 8 weeks, which should be enough to get your hands dirty, if you'll pardon the pun. It'll be enough to make you more comfortable. Anybody else?
So we have to request that they sign off on an evaluation for each week, and then we turn that?
No.
Okay,
The evaluation is done at the end of the semester, or the end of your clinical period. So if you're getting towards the end of the clinical period, you would get the evaluation on you by the preceptors is 3 pages long.
so what are we turning in every Monday, our schedule? Like what, the hours that we put in?
If you do any competencies,
Okay.
then you're going to hand them in to me on Monday.
Gotcha.
If you don't do any competencies, then that's fine, but don't leave it too late.
Would the clinical facilities report back to you on the clinical attendance, or do we do that?
Oh, yeah. And you do also. As I said, if you do not attend, then I'll get a phone call from the clinical site saying, I haven't seen so-and-so today. Do you know anything why he or she is not with us? And if I haven't had a phone call from you, I feel like an idiot because I don't know. So call me, call the site. They will do a mini orientation with you when you get to the site. Part of that orientation will be for you to ask for a contact phone number. because blame it on me. Professor Wiggins King says I have to have a contact telephone number in case I get stuck in traffic. That's fine. So they'll give you a phone number. It might be a phone number to the front desk, to the receptionist. They may give you a direct phone number to the treatment machine that you'll be on. I don't care, as long as you have a contact phone number where you can either talk to one of the therapists or leave a message with the receptionist. Any other questions?
Do they have like a specific outline for like the 90? Like, do they have something that they go off of to be like a point system?
Well, they have a preceptor manual, the same as you have a student manual. So they'll know what you need to do. But it's up to you to decide what you want to do. You know the competencies that you need to do. So it's up to you to tell them that, okay, I have all these competencies I need to do. They'll usually start you off with an easy one and then work up from there. So don't get too excited if they don't start you on competencies the first 2 weeks you're there. You have to get used to them, they have to get used to you, you have to get used to the patients, and they have to make sure that you're comfortable with the staff, with the patients, with the machines. Because the last thing they want to do is fail you. They all remember when they were students. So they're trying their best to get you the stuff that you need.
I just mean like the specific, like how do they know if you got a 90? Do they have like
Oh,
Something
a
about,
list
like they
of-
score it and then they divide it by whatever.
Yeah.
Oh, I
So
must have missed that.
each little portion of the competency has a score.
Okay.
And that gives you what you need to do. The majority of the time, if you pass a competency and all the information is approved, then you've passed. Anything else? No? Okay, so I will be giving out the student manuals. I have it on electronic form. I did, the last couple of years, do a printed version in a binder. Which would you guys prefer? I can do both.
I like the binder.
You like the binders?
I like old.
I like both.
Pardon?
Can we
Yeah.
like have it
Really,
sent
both
to
would
us?
be ideal.
too?
Yeah,
Yeah.
well, we can do both.
'Cause I
If
like-
I forget my binder or
Yeah.
something, I can pull it out.
Yeah, I'd
the-
prefer
the-
the binder, but
Yeah, okay,
I like to
that's
have
fine.
both.
So the idea is that you take the binders to the site. The other thing I would suggest that you do at the site, you have a shelf or something that the therapist will tell you, yeah, put your binder up there, so it's there for us. Remember that in the binder, there's one copy of each of the competencies. So there's a copy of the CT competency, there's one copy of that, there's one copy of the treatment competencies. So the idea is that you just copy them before you give them to the therapist. And that's the idea of the electronic version, because we were finding when we didn't do the electronic version, is that the more we copied these forms, the lighter they got. So if you can print out the copies from the electronic form, it makes it easier for everybody to read. Does that make sense?
Mhm.
Okay, good, okay. So any more questions? No? Okay. So as I said, we'll go over the actual competencies later on. I just wanted to give you a start
So these clinicals, I'm sorry, will start this summer?
They'll start in the summer, yeah. In May.
In May?
Yes,
That
that's
seems
the
like it's-
start of the, that's the start of the summer semester.
Summer term.
Do you know what dates we're out for in between?
I can find out for you.
If I remember, we end like
I
really
think it's
early
only
in
a
May.
week.
I
it's
think
only
the
a
last
week.
day
I
is
can
like
find
May
out for
5th or
you.
something like that, or 3rd.
Well, I mean, like, we're only here till Wednesday, so technically we would have the Thursday, Friday
Right.
before.
Yeah, it is like a week, I think, between
Yeah, I think
the
it's only a
beginning
week.
and the end of.
The only time we get more than a week is at Christmas.
Yeah, I was
Or
curious.
should I
what
say
dates
the
were.
winter break? Christmas break, I still call it Christmas break, and I apologize if I'm insulting anybody. That's how I was brought up, so that's what I say, and I hate, I try to be politically correct most times, but I still say Christmas.
Are the summer terms the same length as the spring
Yes.
and fall?
Yeah,
Okay.
yeah. Yes, ma'am.
When would we know where we're going, hospital-wise?
I'm hoping to get them before you leave for the break.
Oh, spring break this spring?
No, not spring break, no. Because of what's happened with COVID and stuff,
Yeah.
I'm still trying to get the last group finished the clinical. So it will not be, I won't be able to find out where you're going until probably we finish spring semester. I'm hoping to give you it before you go off for the small break between some spring and summer,
Oh, okay, yeah.
okay?
And in the fall, we go to new sites?
Yes,
Okay.
yeah. And the idea behind that is, the idea behind you splitting up your sites is that not everybody does the same thing the same way. Everybody has the same response or the same treatment, but the procedure to get there differs, especially if you're going from a small facility to a large facility or vice versa. So there are several hospital sites, there are several standalone sites. So it's good if we can get you into a variety. Okay, so the other thing I was going to mention before we start actually doing something clinical is that what was I going to say? Oh, yeah. I haven't given you a test on head and neck yet. So I'm going to put one on campus this afternoon. And it will be due, we'll make it Saturday night, Saturday midnight. Does that give everybody enough time? Okay. Yeah?
Yep.
Okay. So basically, it will be valid from probably about, I'll make it 5 o'clock on Wednesday tonight till midnight Saturday. Because I still have to tend to be carried. And I will make it, the last time we did this, I only allowed one attempt, right? I'm gonna make it multiple attempts so we don't have a problem this time, okay? Okay, so we were going to do electrons on the machines, right? We were?
I think so.
Yep.
Yeah.
Okay. Let's move forward. Let me get a chair. Take a chair. Okay.
I was like, I
I don't remember the
Okay.
things called.
So you can go ahead and pick up the Alexa hand control.
Longitude.
And let me get a
Oh my gosh. Height.
patient for you.
I don't have the cheat sheet.
Something.
I don't have the numbers, my cheat sheet is my.
It's height, collimator,
Hang on. Let me get this.
Lateral longitude, that's just.
yeah,
a-
lateral,
a date.
longitudinal, and then vertical.
Lateral.
And we'll do
This thing. I feel like I'm too close to it.
What are you doing?
Just grab my cheat sheet.
Oh, I thought you didn't have it.
Let me see, I think it's in my bag.
Okay.
Do you want to use mine?
Mine's on a clipboard.
Here it is.
So I want you to start off with the patient down and out of the way of the machine. And remember, the electron cone is very close to her neck. So
Sit down and away from the machine?
that is correct, yeah. So down first. Okay, so you're setting up as if the patient is just coming into the room. Okay, so bring the bed before you get too close, stop. Remember what we said about bringing the patient out before you got too low, so that the majority of her weight is not hanging on the edge of the bed there. There you go. Okay. Good. A little bit more down. That's
A little bit
fine.
more down?
So drop the bed a bit more. Okay. Okay. So what you're going to do here is you're going to set up a patient on her, centered on her right clavicle. And I will alter the field size.
How far up should I bring you?
Well, you're setting up what, somebody tell her what distance the electron is done at. Pardon? 100, yeah. So you want to set up with an SSD of 100. No, don't worry about SSD.
Oh, okay.
Remember, the electrons obliterate the SSD. So what do you use to get 100 SSD if you have no?
Oh, to line up
ODI.
the lasers and the field lights.
Exactly. So you're going to do this. Go ahead.
I cannot see it lined up, so how do I,
Well, you have to get it closer to 100 first. Don't ignore those. Ignore those. You're not gonna.
so I'm looking at I'm trying to see.
Yeah. Well, your laser lights have to be at least here, right?
Oh, okay.
So
mine.
bring it way up. Way up. Just remember you're going pretty close to your patient here. Stop.
I don't see a laser on it.
So, no, okay. So, what are you going to do? Remember my mantra of en face. Is that en face? Yeah. The en face,
That needs to be parallel to.
it does.
the
Is that
surface.
parallel to the clavicle? How are you going to make it parallel to the clavicle? People can help.
First thing that comes to mind is tilting her, but that's not something we've been doing, so I'm going with that's
Well-
not the answer.
You don't have to tilt her.
Can you
What would you do to,
rotate her
Yeah.
the entire couch?
you rotate the couch? Yeah.
Is that the ASU?
No,
It's the eyes of
Number
the
five.
rock.
Number
it
five?
should
Oh,
be
rotate,
rotation.
okay.
Yeah. The other way. Yeah. Keep going, keep going. It's our right clavicle, so that's why we're going that way. Okay. Stop there. Now, what else are you can you actually move? Right, move the gantry. Now remember, her head is there, so be careful.
Parallel.
Looking at it this way, you weren't as close as
A little
you
bit
thought.
more. Okay, now okay, stop there. Are you still on your clavicle?
No.
We'll move it, so you're gonna have to raise the bed up. Keep it coming.
Oh my gosh, that's
Keep it
close to
coming.
her face.
Stop. Okay, so now what you're gonna have to do,
Longitudinal?
you could, but what's that gonna do to the face?
Not sure.
If you move her, everybody else can chime in. If you move her this way, what's gonna happen to this? It's gonna mush her in the face. Okay,
Hard to tell with this.
so what you need to do is move her lateral. Okay. Now, let's move her up just a hair. Stop.
Literally a
Okay.
hair.
Can we
So-
change the perspective so I can just get a better idea of like how close it is to her face? Just a little bit. There we go. Okay, that's much better. Thank you.
Okay,
Not as close as you thought.
Right.
so now you can move her along, now that you see it. Now we would be ducking in and out here, so now you can move her along.
That patient's probably stressed.
Keep it coming, keep it coming, keep it coming. Stop. Now, in real life, the patient's head would be turned, this way. Patient's head would be turned away. So one thing, it gets her chin out of the way, and the other thing is, then the patient can't see what's happening, and she can't see this thing coming down on top of her. So, you see this?
Yes.
What's that?
That would be the midline if she was in the original zeroed out position.
Okay.
So we're not trying to line up this one here. We're trying to line up this one.
No, you're trying to line up this
The top one, okay.
So let's raise the bed just a little bit and see what that does. Stop. You just heard nose. Okay, so
Oh no.
this is a case in point. Remember what I was telling you about the patient, we're trying to treat a patient and the anatomy gets in the way and you can't get 100? So this would be a case in point. You probably could reach 100 if her head was out of the way. If her head was like this. But for this point in time, say the patient can't turn her head, so we're stuck with this like that. She maybe have a C-collar on and you can't turn her head. So in that case, what would we do? We have to get her treated. We can't treat her at 100. What do we do?
But they have to adjust the dose based on the.
Increase the SSD? maybe?
You increase the SSD, and of course that would alter the dose. Well, it wouldn't alter the dose, it would alter the monitor units. So, what is the reference monitor units per MU? Anybody remember? The number of monitor units per MU is 100. 100 monitor units per MU. So, or 1 monitor unit per MU. So, we can get it to 100. The 100 is right here. And we're touching her nose. So basically what we would do in the clinical setting, if we couldn't move her head, we would see, okay, let's see if we can get an SSD. So we can't because you can see it here, but the electron cone is stopping us from seeing it here. So what we would have to do is measure. And we would treat this patient at either 105 SSD or 110 SSD.
Do you think we could get closer if we angled her body
No,
differently? This is
it's just the nose. It's
Okay.
just the nose and the chin. You can't get away from that. In real life, you could turn her head that way, but in this particular scenario, no. That shows you how kind of difficult it is to do electrons.
puzzle solving part.
Yeah, and this is why it's called the clinical setup, because depending on how she lies, your angulation would be different. Okay, so that was a difficult one to start with, but that's fine. So let's bring the gantry up to 0. And you can bring the patient down. Get the patient out of the way of the machine. You're going to, okay, now you're rotating.
Do you prefer to let them down before we rotate the couch back?
Doesn't really matter.
First? Okay.
And if they wanna go for a ride or not.
Yeah. If the patient has never done this before, you have to make sure they know that it's going to turn. They may only be used to you moving it up and in. And once you start turning, they'll think, what's happened, you know? So you have to let them know that you will be rotating the bed. Okay, so she's now off. Whoops, sorry, that was my fault. She's now off. Bring the bed down again, I'm sorry. That was me. I meant to hit lights and I hit home, which means that it goes back to where we were. Okay, so bring the bed out and we'll start from something else here.
She got
Okay.
surgery instead of bringing.
Okay. So, does that make sense? Okay, so next. Okay, so which machine do you want to play with?
I'm gonna do the Alexa.
You go with the Alexa,
Yeah.
okay. Okay, so in this particular case, we want you to do a right rib electron. I'm not gonna say any more. The right rib. I'm not turning the lasers on until we get up a bit higher here, so. Okay. So lasers are on, the field light is on. Okay.
Sorry, quiet.
So right anterior oblique rib. So what are you trying to do?
Trying to get the midpoint of the lasers that hits the center of the
Okay.
ring on the call.
So why don't you drop the bed and see what that does? Okay. And move lateral. No, okay. So raise the bed and see what that does. Keep it coming. Okay. Now you need to move lateral because you're off of the rib. There you go. So drop the bed just a little bit. And move lateral a little bit. Keep it, there we go. Okay, move lateral a little bit more. There.
Need a zoom option on that thing. On the controller. A lot of back and forth. There you go.
Not quite there. So so let's drop the bed and see what happens. Of course, in real life, you could see that better.
Okay, so what's the objective?
You're trying to get the lasers
Lined up with that thing.
on the crosshairs.
On the field line?
Like the lines that are on the field light and the green line laser
Yeah.
lines, you wanna line those all up.
That gives you 100.
Running down the center right there?
Yeah, so you have
So
the
move
X
it-
of the
if
laser,
it
and you have
doesn't
the X
work,
on the white line,
raising
so
it,
you wanna get those
lower
lined
it.
up over the rib.
It's the only way you can learn. Okay. So let's raise it up. No, raise it up a little bit.
We're gonna be so close to it.
Stop. That's okay. Now move lateral. Move her away. The other way then. Okay, drop it. Drop the bed. Okay, no, going the other way. You see what I mean? It's just, if it doesn't work one way, do it the other. Okay. So move her to us. Laterally.
Move it all. Breathe.
Yeah. So now you can drop the bed. Okay, no. You have to angle the gantry a little bit more. Okay, stop there. Okay. And move the bed, move yourself away, or move the patient away. And now drop the bed. Or raise it.
It's like a puzzle.
See it coming? Okay, you're okay, keep coming. Keep coming.
Oh, boy.
Yeah, unfortunately, her
Oh, boy.
breast is in the way.
Well, that's unfortunate.
So again,
SSD, yeah.
we have to use an SSD. The extended SSD. So that's probably about 103 SSD. It is very difficult to figure it out, and that's why I'm doing this, because setting up at 0 and 90 is easy. This stuff takes some figuring out, your spatial orientation, shall we say. Okay, you get what we did? Okay, so let's get the patient off. We can take the lasers off. We'll take the field light off. Just because you were so close there, I would have dropped the bed just a little bit. And remember, she's pretty close to the machinery, so get the bed away a little bit as best as you can without knocking her nose on the machinery. And these lines that you see are where the field is. These 4 lines that you see there. Everybody see them? Those are the outside of the
Can you
field
zoom that some?
edges. Excuse me?
Can you zoom that some, please? I
Yeah,
can't see how far the bed is.
okay, so you can drop the bed a bit more, let me get her out. There we go. Okay, so now, Mrs. Smith, you can go away home, see you tomorrow. Okay, next. And which machine do you wanna use?
I'll use this one.
Oh, okay. Let me do something else here first of all. Let me. Okay,
Oh, her head.
pardon?
Her head is missing.
Oh, her head is missing, okay, well, that's fine. There she is, yeah, okay. So in this case, I would like you to do an electron setup to her upper thigh, sort of right here,
Okay, right.
okay?
Wait, or what?
So, right about here.
Okay.
And it will be her left. Excuse me, her right. So I'm gonna put the vein lights off. And I'm gonna bring her in a bit here. Whoops, sorry, let's bring. There we go.
She's very close to that thing.
Okay. So So let's put the lasers on. I'm just gonna, bear with me for a minute. I just wanna get this back to where we were again. Okay. Okay, go ahead, sorry. And here's the field light. Hit her booty. You might want to just lower her, yeah, because you need to get, that's fine, you need to get over the hump in her thigh without hitting it.
How high on the side?
About there, okay. Now, what are you gonna do now? Yeah, go ahead, bring it over, okay. So. Okay, so now what?
It almost looks like
It
that.
kind of looks like
Yeah.
from here, but I
It
don't.
is, it's closer this side than this side. You see the difference in the light field here and here? You're on a slope.
So longitudinal towards her head maybe a little more? Is that what you want?
Well, no, what I'm talking about is you're not on fast. You're not
Oh,
parallel.
parallel, okay.
So what,
To the
to
surface.
get her on fast or to get her parallel, what do you have to do? Rotate, yes. So you're going to rotate her which way, or does it matter?
Her head that way.
Okay, go
I
ahead.
think. I don't know.
Yeah, well, go ahead and see. You know, if it doesn't work, we'll do the other way.
That's why
So
we're
go
doing
ahead,
this.
that, keep going. Yeah, okay. And in this case, I would suggest you go to, all the way around to 90. Okay. We're there? Yeah, okay. So now, let me see if I can get a better angle for you. Oh,
Yep.
okay.
I didn't even know you could go that way.
Kind of more like.
From above,
Yeah.
beam's eye view.
Okay, so I'm gonna take the lasers off for the moment. So. You're on a slope. So you've got it angled, the bed angled. Now what do you have to angle to get it parallel? Hmm? The gantry. Okay, go ahead then.
That's ridiculously small bars, and I'm like, what the heck?
Keep it coming, keep it coming.
I was watching a video of somebody who was changing the electron cone thing, and they were really heavy. Listening to him
They
put
are.
them in,
They are.
click in, and they're like really, really heavy.
Yeah, this one, the smaller ones aren't quite as heavy, but once you get to the bigger ones, they're really heavy. So, what do you think? Is that parallel? Let's see.
A little off.
Little off, not much though. I would say that was pretty good, to be honest. That's good. Okay. So now you would need to get this to 100. How would you do that?
Well, we gotta line it up. So,
Yeah, so how do you get from where your lasers are to where you need them to be? You would drop the bed to start with. Okay, so drop the bed. Keep it coming. Keep it coming. Good. Okay, stop there. Now let's see where we are. Got her to. Okay, so. Try dropping the bed. Okay, in that case, raise her up. See where the laser's going? Here comes the laser. Keep coming. Change the angle. Stop. Down just a smidge. Up, up. There, good. Okay. So there is the patient on en face and at 100 SSD. You'll notice that electrons, because they have this huge electron cone, it does look as if it's coming close, and it does. But that's the beauty and the drag of having to do electrons. Okay. Make sense? Good. Okay, so now you have the job of getting her down off the machine without hitting the bed.
So let me ask you a question. So that light's kind of hanging over her side and down
Yeah.
onto the table, and that's the way that would.
No, this is just a 10 by 10. Normally, we would do a smaller field.
Okay, so it would be all right.
That's correct,
Okay.
yes.
Are electron treatments almost always on FOSS?
Almost always, yeah. So what are you gonna, okay, we'll do it that way, okay?
get her enough away from the.
Yeah. And because of how close she is, if you rotate the gantry, she may, or you may hit this with this. So move her along that way a little bit. And then, okay, that should do. And now just rotate her back to 0. Good. Wonderful. Okay. And obviously, as I keep saying, with a real patient, you wouldn't necessarily go that fast.
Right.
And in all seriousness, have patients throw up if they, they've gone that fast, so. Okay, and everything's back to,
Kind of surprised that they built machines to be able to go that fast. It's just,
well, it all depends on whether it's a patient or you're doing measurements.
oh yeah.
So the measurements are done on the treatment machine as well, so you wanna get them fast, but. And then if you want to get the patient off in an emergency, you have to go that fast. Okay, thank you, ma'am. Next. Oh, what happened? Okay, go ahead, dear. So, are you okay with the Electa?
Yeah.
Nobody wants to try the variant? Oh, I'll try not to be upset.
I just want to get used to this one.
Okay, so in this case, we are going to do, the patient has a plantar wart. Anybody heard of a plantar wart? Where is it?
On the bottom of your
On the
foot.
bottom of the foot. So they actually have something which is called Kaposi sarcoma on the bottom of her foot. So let's set her up for a field on the bottom of her foot, the right foot, the instep, or no, excuse me, the ball of her foot. Maybe, we'll see once we get there. Okay, so how are you gonna, let me just, get a smaller field. The reason why it was very big is that was a 20 by 20 field size. Whereas for something like an electron, it'd be something like 10 by 10 or a 10 by 8. So that's why it was showing over there. So let me get this.
That's treating with the electron cone. Yeah. Very uncone-like, like an electron box. Electron frame.
Okay, so what are you gonna do? Okay, I'm gonna raise it up.
So what I
Is there any, can you move her any further out?
Yes.
Okay, move her further out then.
So what we're doing right now with the trial and error and trying to find the right angle, is this commonplace for something we're gonna have to do, or do they come in typically with, not necessarily a plan, but a setup that they specifically want done? Like, we want this angle.
Well, no, what the doctor would say, okay, we have, an area on Mrs. Smith's posterior upper thigh.
Mhm.
I need electrons treated.
And then it goes to us. Okay.
Yeah.
So then, yeah, we would be, so this
So
is
this
all
is, as I
us.
said, this is a clinical setup. The first day is always the worst. Once you do that, then you can write
Record all your,
down
okay.
where the angle is, where the gantry is, where and it's normally in approximately the same place, but depending on how the patient lies.
So I could say that this is not as precise as if we were doing photon. I mean, it's pretty precise, but not specifically
Well,
like
again, it's a clinical setup.
per
You are
patient.
treating the marks on the patient.
Do they have marks for electron stuff usually? Like
You
tattoos?
usually have a center cross, the doctor probably puts a center cross on. But your job as a therapist in a clinical setup is to position the patient as the doctor wants, and he'll be hanging over your shoulders watching you. And then once you have the field size and the angulation correct to his satisfaction or her satisfaction, he'll say, okay, put the marks on. And that's what you'll do every day.
Okay.
And the patient has to keep the marks on. Okay, so sorry about that. Go ahead. So you've got her.
Can I get like a new angle on her foot? Like that, can you move the angle?
Oh, yeah, sure. Sorry. Try that. Now, how are you going to get an en face setup? And I'll move the angle. I'll move the camera to suit once we get this done. So how are you going to move?
Maybe
First of
rotate
all.
This way?
Say again?
Rotate this way?
No, you would
No?
rotate away from us.
That way?
That way, yeah. go. And you'll see why once we get it there. You can go a little faster. I don't think the patient's gonna object.
Ready?
Okay, so, now what? So you've got your couch rotation at 90. Now what? Pardon? Well, you have to get a field site, a field size, and a light beam. So you're trying to get en face, which means you're trying to get parallel opposed. Or you're trying to get parallel. What would you have to move to get the machine, the gantry? So rotate the gantry. Yeah, you're going the right way. Go ahead. Keep it coming. Keep it coming. Okay, keep it coming. So stop there. Now, you see where your field light is? So you're gonna have to do what? To get it back on the foot.
Fire
Yeah? Keep coming. Okay. So can you move her
forward.
longitudinally? Yeah, away from the gantry. If possible. Good. Okay. Now, stop there. Now let's put looks like we have to move lateral, doesn't it?
Yeah.
Okay, then move it lateral. Good, good. Let's see if I can get a better view of that. There you go. So who else thinks that's, do you think that's on fast?
Can you zoom in a little bit?
Yeah.
Everybody think that's on fast, apart from the lasers? Okay, so let's see if we can do something to get it at 100 SSD. Bless you. So move, bring the bed in a little, or bring the bed in towards the machine a little bit and see what that does. No, just the bed, just the patient. That's okay. No, wrong way,
Toward the machine?
towards the machine.
Oh, like longitude.
Yeah, longitudinal,
okay.
yeah. Yeah, you see what's happening?
Fairly.
Yeah, so this laser started off down here and now it's moving up. So what you have to do is bring the patient longitudinally again.
Toward the.
Yeah, towards the machine.
Oh,
That's okay, don't worry, that happens, keep it coming, keep it coming. Okay, so now you have to raise the bed and be careful because of the machine.
We need a new angle here to see it.
Here it's coming, Keep it coming. Keep it coming.
It's almost there, but she's so close to it.
I know. Keep it coming. You're doing good.
You wanna like step over here so you can see it better, but it won't help?
I can't see anything.
There, good. Okay, we'll leave it there without taking the patient's foot off. Yeah. So, do you see what we're doing? You have to, if you're, especially at an angle, you're moving it one way and then having to move it another way. So you're moving it either up or down or in or out to get, it would be, if it was straight up and down, that would be fine. But it's not, these are all angles.
So doing all this, you said is normal for like the patient's first time?
Yeah.
So you figure out.
Yeah, exactly. And even after the first time, you still have to reproduce it. So,
So you get used to what.
till you get used to what you need to do.
And with electrons, we would still be using immobilizations and stuff just for
Not necessarily, oh
reproducibility?
yeah, bring her down. Not necessarily,
No?
no. Not necessarily.
It doesn't make it more easy for reproducibility at all? To do, like, if we were doing her
With-
foot?
Or when you're doing something like a foot, yeah, you would probably use immobilization. But for a rib or something, you may not need to. If you're doing a boost for something, then you'd have them in the same position as you were for the breast. Or for, if you were doing a breast boost, for example, and that'll be the next one I'll show you. We'll get there. It would be, the patient would be in the same position as she was when we did the full breast. So if they were done on a breast board, everybody knows what I mean by a breast board? Anybody seen a breast board? I'll show you it when we get, this is whatever the name is off here. Okay. Okay. So she's happy, she's off, bye-bye. Okay, let's just put that, hand control back on there. Because we'll do please and thank you. So this is what a breastboard looks like.
Good job, man.
Oh, your patient. Sorry.
Whoops.
Oops, yeah, so we'll just ignore that.
That almost looks like something you would birth a child with. Leg stirrups.
Okay,
Sounds like a lot of fun.
let's just take it down and we'll start again. Yeah, okay. So here is a breastboard. So this is a breastboard. So what happens with the breastboard is that it's an angled board. This is, each manufacturer has a different board. So this basically, the patient lies on this part of the board. The rear end goes, excuse me, the rear end goes about here, the chest lies on here, and this part is for the elbows, so it goes up like that, and this part is for the wrist. So both arms are up like so. And you can vary the angle. So that, I believe, is, oh, come on. Oh, So that is a 15-degree angle. This is a 10-degree angle. This is 0-degree angle. So, and this is a 20-degree angle. So you can see it varies. And each one of these has different settings. You can see, you can angle them. You can put them higher or lower. You can angle them. Here you can drop them down. You can move this across. So you can angle them for individual tastes as far as the patient goes. So each of these positions would be on a setup sheet. So that's what a breastboard is. So if we were treating with a breastboard, the normal breast, if we went with an electron boost to one of the breasts, we'd have the patient in the same position. So let's see if we can do this. I'm not sure whether it will allow us to do it or not. Let's see.
Nope.
Oops. Okay.
They
let's
almost
take
thought
the
of
breastboard
everything.
away. I'm gonna have to get rid of that. So, okay. So who's next? Which, okay, I'm feeling slighted now.
I think we're just
So,
trying to get
okay,
used to it.
so what, oh, hang on.
Yeah. We've all been on Varian twice, so this is what, our second time with Electra?
Okay, yeah, sure. Yeah, sure. Be like
I like that it's the, whatever you call it, not the.
The wheel. Yeah,
Yeah,
I
but
know,
I
me
don't
too.
like having to switch the function like that.
I don't mind that.
Actually, I
I
kind
don't
of like
mind, yeah.
Thumb wheel?
it.
Yeah, I
We like the
I
thumb
like the
wheel,
thumb
it's less
wheel.
touchy than the
But I hate
toggle,
having to change the function like,
the function
I
reset
also
button.
like
numbers like one,
You're
two,
changing the
three,
function
four,
on
five.
these, and it's actually more difficult to change the function on these.
Yeah, she's saying
That's
she
what I'm
doesn't, on
saying.
this one, she doesn't like the function.
I hate having to change the function, but I like the thumb wheel better.
I don't mind the function, it ain't that big a deal once you get
Okay.
used to it.
Okay, let's get you an electron here.
Mhm.
Yeah.
I will.
Like Morse code.
Yeah.
1,
If
2,
I
1,
reset
2, 3,
every time, I can
1.
do it, but it's so slow. Yeah. I hate to read.
Okay. So let's drop the bed here so that we can make sure her chin is not being
Smack it.
hit by anything. Okay, so what I'd like you to do is we're going to do a breast boost. And this will be to her right lower quadrant. Her right lateral lower quadrant. Her right lower quadrant. And I'll just change the field size. So a right lower quadrant. And remember, of course, in real life, her arm would be up. Right? So, let's, lights, lasers, field.
Yeah, that's it.
Like that one?
That'll do, yeah. But,
Do I need to move it up?
well, you have to get her in position first, which means you're gonna have to angle. Because the right lower quadrant would be over here somewhere. These days I'm gonna trip over one of these. Okay. Okay, a little bit more maybe. Okay, now. What do you have to do now?
Would I do it?
To make it all fast, what would you do?
Would I rotate the gantry first? Or
You
the-
can,
Okay.
yeah. That would get the angulation properly done, yeah. You can go a little faster than that. Okay, let's leave it there for the minute and I'll change the, position. Oops. Trying to put this, here we go, there, okay. Now. So.
There we go.
I'd like you to raise the bed a little bit more. We're not quite where we want her to be. Okay, there, good. Now, the angulation, is that all fast?
No.
Okay, so go ahead and see what you can do with that.
Would I rotate the back?
Rotate the bed. I wouldn't do that quite yet, so let's rotate the gantry first. A little bit more. Okay, now, that's good on fast that way, okay. But what about this way? What about soup to imp? You have a little bit more, you're a little closer here than you are here. So what we want to do is move the patient that way. So if you rotate the bed or the couch towards us. Okay, good. A little bit more. Keep going. That's great. Okay, there. Now, let's see what we can do about the 100 SSD.
Would I move the top?
Try it. A little bit more, a little bit more, a little bit more. Wonderful. A little bit more. Just a hair, there. So, when you're working with on fast, sometimes you've got two directions. So here, it was good on fast this way, but it wasn't this way. So when we moved the machine, her feet towards us, it made it on fast in two directions. Yeah,
Now for treatment, would the patient have to wear a special kind of bra? Like, because I know some bras have wire in it, I don't know, would that be an
the
issue?
patient is not wearing a bra.
She would just wear a gown, right?
She
If
just wears a
anything.
gown, and the gown is open. With with any type of treatment, we have the patient with no clothes on over the area we're treating. We do not treat with clothes on. Does that make sense?
Mhm.
Why do you think she would be wearing a bra?
I just was looking at that and I was like, that's kind of like right underneath where the wire would support at.
Well, we would suggest that the patient doesn't wear a wired bra. And the reason, can somebody tell me a reason why? You want to get your patient down, that's fine. Can somebody tell me why?
Probably like maybe inflammation.
Say again? Pain? Not really.
The metal and the wire, I would think, would affect the dose.
No,
To the
well,
area.
not if she's not wearing it when we're treating her.
Oh, you mean not to wear one at all that
Not to
day?
wear one at all.
Oh, afterwards. Well, yeah, irritation.
The irritation.
Sure.
So if you have something tight
I thought you meant during treatment.
or something that is hard against your skin, it's gonna make you irritated. And if we're making her irritated, if her skin is red and itchy to begin with, then anything that is tight or anything that is rubbing is gonna make it even more so. So that's why we try and get the patients to wear sports bras.
If,
Or something. The other thing that one of my physician friends used to say was, get an old bra, one that's stretched out a little bit. Wear it for the length of your treatment, then throw it in the fire.
ceremonial.
Yeah, so usually we suggest a sports bra or something looser. Some patients would say, okay, do I have to wear a bra at all? We say, not if it's, some ladies cannot go without a bra.
I need a t-shirt that says, I'm in radiation, no bra required.
Yeah. And some ladies say, oh no, especially the older ladies will say, I can't have a bra.
One of those little nipple pads.
Yeah, so, the idea is to be comfortable. Good, thank you, ma'am.
She had brought up a good point. If this is a very large-breasted woman, what's the best way to ensure that we're treating the right spot every time? Because they're kind of, very mobile and jiggly and hard to keep in place.
Exactly, they are,
Mhm.
they are. And that's a good question. There are, having said no bras, they have got treatment bras that some of the manufacturers make, and they're purely for radiation treatment for what my mother would call well-endowed ladies.
Mhm.
And the problem with them is that they add to the skin reaction. So there's really no good way of doing an electron treatment on a large-breasted lady, except if we can just get them in the same position. Sometimes we use tape, paper
Okay.
tape, just to keep them in the same position. Apart from that, okay, who's next? How many more people have we got? 3, 4, okay. We may have to carry this on till next week. Okay, so what I would like you on this lady to do is I'd like you to treat or set up her right lateral maxilla. She has a node right here on her maxilla. So that's what we're gonna treat. Let me give you a field light. And lasers and field. Now sometimes what we do is take off the lasers because they can get annoying to begin with. Okay, so start rotating because you're gonna hit her nerves if you're not careful.
Okay. Do I lower her first?
No, you can move, yeah, you can move.
So she so I'll be like, I'll move her too.
Okay, go ahead. So you have to be careful when you're looking at this because if you're not down looking like this, you may look as if it's gonna hit your nose, but it may not, so. Let's just rotate the gantry a little bit and see where we land. Good, keep going. Okay, stop there for a minute. move her lateral away from us, just to be on the safe side. Okay, now rotate back, and rotate the gantry again. Okay, and stop where you think is good. Okay. Okay, right there. Okay, so let's put, do we have a field light on there? No, there's the field light. Okay, so. Okay, so is that, do you think that's en face or parallel?
That looks
So-
almost mandibular. Are we supposed to go up higher on the maxilla? Or is it just the angle I'm seeing it from?
Well, depending on where her lump is, yeah.
It looks like that, like, here, too, so-
So let's, move the patient inferior, please. The other way. Okay. So now you're going to angle the gantry to see if you can make her or make the field a little more en face. There, let's try that.
It would be cool if these companies came up with an app that you could put on your phone and practice angles and positions and that kind of stuff.
Wouldn't make them any money.
You could,
Might educate people, students, it would be helpful.
It wouldn't make them any money.
So it needed to be funded.
Would
Every
I
new
need to feel
position
like
is an
to
ad.
Be sure,
You've got the field light.
so what would I,
So you would angle it a little more. Keep it coming, a little bit more, a little bit more. Keep it coming. Okay, so you notice, ladies and gentlemen, that we have a little bit of the field light coming down onto her neck.
Mm-hmm.
We want to get rid of that. So which way do you think that we need to move the couch to get rid of that?
Lateral to her left.
Lateral?
I would drop her a little
Would dropping her a little bit take care of, we're talking about
They would move it up towards the nose off
this
the
little
neck,
bit
yeah.
here. But I don't want to, I want to keep it where it is. So how do I get rid of this little split here?
Maybe
So
rotate her.
we
Collimator?
will rotate her.
Oh,
You could use the collimator, but for the moment, we're practicing rotation. So let's rotate her. Yeah, okay, keep it coming. Keep it coming.
Uh-oh.
No, so that's obviously the wrong way. So let's move it the other way. Keep it coming. Now be careful, because this is where you have to watch what you're doing, because if you move it a little bit further, you notice what's happening. You're awful close. Let me see if I can get you a little bit more. So we've done it a little bit. Let's try going a little bit more. Okay, so that's fine, leave it there. And that's about as close as we're gonna get, I think, to this.
I wouldn't,
Sorry, go ahead.
I wouldn't be able to bring her closer?
You could bring her closer. You could move the lateral, you could move the patient lateral on the bed. See what that does? The other thing you can do
I feel like it's
is-
not parallel. either.
right, I was thinking that too.
use the collimator to to get rid of that, to angle it off that neck. That's good, okay. Now, they're saying that it doesn't look parallel. So let's move, so you want the gantry going where? Which way do you want to move it so that it will be parallel? Gantry down,
Yeah.
okay, go ahead. Keep it coming,
There, yeah, that looks better.
that's better. Okay, so see how long it takes? This would be what it takes on the first day.
I feel like
Only a little bit faster.
for
because-
me, it would be more than 15-minute time slot
Oh, yeah,
to get to that.
exactly. Because when you're a little bit more experienced, you can visualize what you
Mhm.
need to do and do it.
Is the first appointment the same amount of time as all the other ones?
No.
Like they don't give you a little extra time
Oh,
during
yes,
the
they
first
do.
one? Okay.
Oh, yes, they do. For a first setup on a, you can start moving again. You can get her down. For the first appointment in an electron or a clinical setup electron,
Mm-hmm.
you probably would be given half an hour, 45 minutes,
Oh, okay.
depending on,
We didn't do her 100.
no, we didn't, but that's okay. Depending on how well you know your physician and how likely it is for him to have him or her have something weird. The majority of radiation oncologists are still male. But the majority of females coming out, the majority of medical students coming out of medical school at the moment is female. Okay, thank you, ma'am. Okay, oh, let me move this out of the way here. So you're talking 10 years down the road, right?
Yeah.
At least?
Yeah.
Okay. Okay, so, next,
She's like,
next. You're okay with this one? Okay. So, for this.
You're right, so I'm in here to get
let's
this once and
change
done
it up.
thing.
Let's do male. We've been doing the females all along, let's do males.
For you.
For me.
I can promise this is it for me. I am done with the D.
So what we have to do is
Yeah, yeah.
get our patient down out of the way of the machinery. Get his head out of the electron column. There we go. Okay, so just get him down out of the way there. Bring him along a little bit. Out.
Oh, the cone.
Yeah.
They still call it a cone. Like the videos that we're watching, he was calling it a cone, and he was showing us how to switch them in and out.
Oh, I have a good idea.
They
Yeah,
slide
okay,
into
carry
this
on.
like gap,
I'm
and
gonna
then
change
click
it
so
up
that you know
to the
they're there,
next
and then
person.
this red
Okay,
light
that's
turns
fine.
green, so it's really
So-
dummy proof to make sure that it's in right. It's heavy.
Let me, okay, this patient has
He's like, do not take this off.
skin lesions all over the top of his head. We like to treat them. So, go ahead.
Mr. Smith, I'm gonna need you to stand up. Just sit under the
Hmm?
machine.
oh yeah, it's working. The whole.
Okay.
I'm definitely seeing a trend here with this on Foss situation and rotating of the couch.
That's how you get your all fast.
Mhm.
It doesn't have to be all the way around as you saw with the last one. You can angle it a little more. Okay. So now what? Okay.
had one. I've had several actually. The one that we were required to have one like that for A&P for lab, and then
But they were longer, right?
it was about that length. But we were required to leave them in the classroom so that we didn't have
Right.
to. And then COVID hit, and I just never got it back.
For that time, I bought a disposable one.
Yeah. Well, and she said because the previous class, if they didn't want theirs anymore, they could just
Yeah,
donate it
I
to the
always
classroom and
thought
she would launder them. And so I'm pretty sure that's what happened to mine. I'm pretty sure mine
What
got,
was that?
for A&P2, and1, we were required to have a lab coat like that. And
Where?
here,
Here.
yeah, yeah, here.
Well, go and speak to the instructor and say, I want my lab coat back, please.
Yeah, it's probably gone now.
It'll
Okay.
probably be like,
It's been 2 semesters since then.
yeah, I had a disposable one, so I doubt they have it anymore.
I bought that one because it was only like $15 on Amazon.
Yeah,
I was like, I
yeah.
did well.
Yeah.
So I guess it worked out.
Well, I used my same coat for 2 years,
Oh, nice.
because I used it for both classes, and then I just left it. But it wasn't one like that.
I tossed all the ones I had for medical and systems. I was
Oh,
bitter.
sorry.
I want to get one though.
Let's take the list
I'm
off.
so cold in nature.
Okay. So I need you to raise the bed up because we're wanting to treat a little more posterior. A little bit more. So, okay, so there.
I like each facility.
So are you
Yeah,
now,
you have to
you're
wear
now
this as
not
the
on
sign.
fast anymore, are you? Okay, so let's put your, there you go. Okay, so ignore the field light because it's just spraying out because of the angle. So let's see where we have the lasers. So in this case, let's move him inferior. Not lateral, no.
Longitudinal.
Longitudinal, inferior. There, whoops, back up, back up. There. So I think you're still not quite on fast. You're gonna have to angle it a little bit more. Little bit. Little bit. And again. And again. That's good. Okay, do you see what I'm looking at?
Can we see it from Beam's eye view to see where it's hitting? We're treating the top of the head,
The
right?
upper one is longer than the lower one to me.
What do you mean?
The upper white lines.
Which upper white line? You're not looking at the light. You're not looking
No,
at
I
that.
was looking at this one to me looks longer than the,
No,
no?
no.
I think it's just because it's forehead.
Rounded it.
Cause
Hmm?
it's like,
I think it's just, she's probably just looking at his forehead.
Yeah. Yeah, that's good, it's on fast. Yeah. Okay, let's bring them back down. With the lasers in this position, you really can't see them very well.
Does Jacksonville have facilities with whole body radiation?
Yes,
That was really interesting.
they don't use them very often, but yes.
That's gotta be tricky to make that reproducible, or I guess if you're doing the whole body, does it not matter?
Different, I feel like, wouldn't different doses go to different parts of the body?
Yes. Well, it depends
It's-
on how you do it.
Yeah.
And we'll do that later on this semester. Show you how
What would you
it's
use
done.
that for?
Pardon?
What would you use that for?
Usually, if it's a child, it's usually leukemia.
Okay.
For an adult, sometimes also, and sometimes non-Hodgkin's lymphoma.
The What I
or
watched was
in some
dermatology.
cases, multiple myeloma. Okay, thank you, ma'am. Next, so one more after? Two. Oh, Lord. Okay. Okay, so let me do something here which is kind of different. This one is,
No, I don't think she would have changed it if it were me, 'cause I never used this machine.
okay, so this is a lady on her side. So what we're gonna do for her, why is she lying the other way around? Okay, so what we're gonna do for her is we're going to treat her hip, her posterior, no, we're going to treat her here. We're gonna have to continue this next week.
Should I lower the bed a little bit?
You're setting up,
Yeah,
yeah,
I would.
lower the bed.
I would.
Just to be safe.
It's not moving.
It's not moving?
I'm holding the
I'm
side.
holding, okay, can someone help her? What do we do when? we're-
Longitudinal.
Longitudinal?
That press the arrow.
Right,
Ah,
correct.
okay. There you
There
go.
you
Okay. So we're going, let's put the field light on. And the lights are off. Okay, so we're going this way. Good. Keep it coming. We might not actually get there, so let's see where we are. Yeah, you just bang the machine with the patient. Oh, boy. Yeah,
You're
okay.
getting fired, you're getting a bad heat you're getting kicked out of the program.
Just tell the patient it's totally normal. We're just testing her.
Pardon?
And so now we're hitting the machine with the couch. It's
Yeah, you are. So let's not do the upper hip, let's do the thigh. Let's do this
I
part.
mean, couldn't we rotate her 90 degrees and then bring her longitudinal to treat the hip like that?
Because you could do that, but for a moment, we'll just do it this way. Okay, so. There's only so far the bed can move longitudinally anyway. There we go. Okay, stop there. That's good. Now, is that on fast? No, okay, so do something to make it to make it on fast. What are you gonna do?
Take the bed.
Yeah? You could do that little thing, yes. Which way are you going? Okay. Okay. That looks pretty good. Yeah, okay. Now, normally what you would do is you'd have a center cross on this, so that when you're moving it along and up and down to get your lasers on, you know where you started, okay? So, let's, see if you can get 100 SSD on that. so you may have to just raise the bed up, yeah. Try that. Yeah, there you go. Keep it coming, keep it coming. Yep, beautiful. Still on fast, a little bit, maybe just a hair. More rotation. Gotcha. That's good. Excellent. Okay. Good. Make sense? Okay. Okay, so, yeah, let's get it done. The other two ladies, we're gonna start with you guys next week, okay? There's only two left, right? Okay.
That's good, because I was gonna be really slow since
That's
this
okay.
was all new to me, this machine.
Well, it's new to everybody.
Oh, you guys have never been on it? When I
No, we
wasn't
did
here?
it last week.
Oh,
Yeah.
you-
Oh, that's right, you weren't here
Yeah.
last week.
So this is the first
That's
time.
okay, so that'll be good, I can kind of.
Yeah.
But
So
this
you'll
is
be
the first time
last.
doing the electron.
I would have
Okay.
volunteered first.
Which all it is, really just
I
add.
looked at the screen, I was like, what the heck is that?
Which means you can fall.
Yeah. Well, you know, you don't have to use the Electa, you can use the Varian, it doesn't matter, if you want.
I really want to try it once.
Okay, sure.
Everyone should try it once. It's an experience.
Okay, so,
An experience, that's like experience.
so why, tell me why we don't often get patients lying like that?
It's hard to reproduce.
Say again?
It's hard to reproduce.
It's very hard to reproduce this. And it's not stable.
It can be wobbly and.
Yeah, exactly, she would be wobbling.
So if you wanted to treat that hip area, you would have them supine.
You'd either have them
There you go.
supine, yeah, you'd have them supine or prone, whichever makes it easier for them, okay? Yeah, so let's just put the light on, take the lasers off.
Is there ever a case that you would have to do this position?
The only case that you might have to do this on is if you're treating a leg and the patient, the physician wants the leg treated this way, sort of this way, you would have to have them lying, and in this case, you'd be lying sort of like that on your side. So we get them, and that would be, we'd make a vac lock for that particular position. So that's really the only way that we would do it. It's really, we used to treat breasts similarly to this many years ago. And we'd have the patient half on their side with a triangular cushion behind their back. And they'd lie like this with their arm up, and we could treat the breast this way. And it worked very well. But again, it wasn't really, well, it was stable because the patient had something to lie on, but it wasn't particularly good. The patients got treated and the treatment worked, and it, yeah. So any questions on the electrons, apart from how the heck do you do it? It's a case of, it's trial and error. If you have a patient that is an awkward position and you need to treat them, and the doctor comes in and says, I want this patient treated and it's up here like on the clavicle or in the axilla, where you know you're gonna have difficulties getting it in. Because you need to get this, and this is a small cone. You have a 25, this is probably a 10 by 10 cone that's on the machine at the moment. You have, usually it's a 6 by 6 cone, a 10 by 10, a 15 by 15, a 20 by 20, and a 25 by 25. And as they go up, they get heavier. So if we were treating the gentleman with the thing on his head, we would use something like 15 by 15 cone, so we would cover the whole scalp. But if we're treating the carposes on the sole of the foot, we may only need a 6 by 6 cone. So it depends entirely on what we're treating, what field size we use, or what cone we use. And it also depends on how big the physician wants to cover. But this is, as I keep saying, is a clinical setup. There is no, for the first day that we're doing this, there is no set instructions. You get the patient on the bed, you see where you want to treat, and you finagle it until you and the physician agrees that this is the correct position.
So there's usually always a physician there to okay
It has to be.
Okay.
Because they haven't been planned. They're coming in. This is a new position for them. The physician knows what he or she wants, and we have to get them into a position which we think that we can do, the patient is comfortable in, and the doc agrees with it. So it's just, you have to deal with it, unfortunately. You have to do what you have to do. And the first day, it doesn't matter what you do, you have to get position on there. And you fiddle and fiddle and fiddle and fiddle, and you think, okay, I've got it, all fast, it's wonderful. The doc looks at it and says, nah, let's do it this way. Let's move the gantry, let's move the bed. And you probably end up back to where when they move the bed, and then you think, well, doctor, I think we'd better go back this way. Oh, okay. And then you end up back where you started before you wanted to move it. It's all in how you finagle the doctor as well. It all depends on how good a rapport you have with your dogs. But once you see these done, you'll understand why. Once you see it in real life, you'll understand why it took you a while to get it done, because it does. And you just have to know how to move it and where to move it. Okay, so I will see you again on Monday. Do the head and neck test. Make sure that you look at the breast chapter, the chapter for breast that I put in the canvas. We'll be continuing the breast setup on Monday. And all the information I put in Canvas.